So this evening, we are going to present or to continue our series on careers in medical specialties. We're going to present family medicine tonight. Yay! We have Dr. Jessica Jones and Dr. Erica Baiden that will be presenting. Dr. Baiden is a family medicine doctor at Granger Medical. That's a little bit west of here, for those of you who may not know.
Actually, we have 16 locations.
16, sorry.
170 providers, okay?
I stand corrected. And Dr. Jones is faculty with the Preventative and Family Medicine Department.
Department of Family Medicine.
Yeah, Department of, yes, is what she said.
I know. Like he's not a part of it. Yeah.
Yes. And yeah, you're both faculty with the Department of Preventative and Family Medicine. She's also a urgent care physician with the University of Utah. And so I will hand it over to them. If anyone has questions, I believe the format is they're going to present, but if someone has a question that's virtual or here in the room, it's okay to ask?
Yeah, of course.
All right. So you can, I'll just bring this up here.
So this is going to be more conversational than lecture. Yes, we have a few slides, but this is going to be more of a dialogue rather than just us presenting to you. So thank you, Richard, for the introduction, and thank you for having us. Thank you, Elijah, for letting us be here. We are really happy to be here. So I'm Jessica Jones. Yes, I'm a family medicine physician. I am faculty here at the University of Utah in the Department of Family and Preventive Medicine. I'm actually in the Division of Public Health. So I teach and advise with our graduate public health program. I am also one of the associate chairs for equity, diversity, and inclusion for the department. So that's who I am, and I'll let Erica introduce herself as well.
I'm Dr. Erica Baiden. I am a former University of Utah alumna. So I went to medical school here, graduated, we talked about that a while ago. And then I was in the family medicine residency. Dr. Jones is actually my attending. And then Richard and I were also residents together.
Are you in the same class?
I was his senior.
Oh, okay.
Just kidding. And now I work at a private practice called Granger Medical. We have grown exponentially in the last 10 years since I've been there to have included 170 providers and then 16 locations. I was a former department chair. I'm now the chair of our lab and diagnostic committee. Then I serve as a consultant liaison for a healthcare company. So family medicine does offer you lots of different opportunities that are both clinical and non-clinical. We can talk about that as we continue this conversation. And I also am a mom, so we can also talk about that work-life balance too.
So what is family medicine? Oh, sorry. I saw the circle there. So what are your thoughts? What do you think family medicine is all about? And online, please chime in.
Preventive care.
Preventive care. Mm-hmm.
I've always thought of family medicine to be like pretty encompassing, so quite a few different things. And family medicine shows a lot of different ways.
I feel like family medicine is the first thing I think of when I think of a doctor. That's what I have in my mind.
Good. I'm glad to hear those. Those are great answers. So the first thing you think about when you're a doctor, all-encompassing and preventive care, all of those are excellent answers. Any other thoughts about family medicine?
That's awesome.
Other than that, yeah. So this is just one definition that some of you might have seen if you've come to some of these presentations before. But so family physicians, they deliver a range of medicine, acute care. So that's if something happens, or rapidly. You have a cold, you got a cut, you can go to your family medicine provider to get that taken care of. chronic care. So those chronic illnesses that sometimes people need to deal with, asthma, diabetes, high blood pressure, the
Mental health.
mental health. Yes,
You do all of that.
yes. So preventive medicine, yes. We want people to come in to make sure that they're as healthy as possible and doing what they can do to stay healthy. So when you think of preventive care, a lot of times we think about vaccinations and things like that. So yes, as when we see the kids, we have our well child checks. We want to make sure that they have all the vaccinations possible. Lately, this past year, we've had adults wanting to get their COVID vaccination. So we want to make sure that people are vaccinated and stay as healthy as possible. And that's one of the major preventive types of cares that we can do. But we also, yes, we manage chronic illnesses. Coordinated care is also huge as well. So if there's something that goes beyond our scope, people are not getting better the way we want them to, then yes, we do refer and we coordinate care with other specialists and other specialties as well.
We do a lot of women's health. That's also important. Contraception, preconception counseling, but we do some non-surgical gynecological management too. So we're here.
Yes, it's all encompassing as yes. So that's just kind of a brief definition of what family medicine can do and what it is. So when we're thinking about medical fields in general, so thinking about you want to be a doctor, okay. There are many different fields you can go into, and typically we categorize them into primary care fields and specialty care fields. And so I'm glad that the first thing that comes to some people's mind is family medicine when they think of doctor, because when you're thinking about primary care fields, yes, there's family medicine. Pediatrics is also in that category, internal medicine, and then sometimes people will put obstetrics and gynecology in the primary care field. However, OBGYN also crosses over into specialty care because they are surgeons and they do surgical care as well. But specialty care fields are basically everything else.
In family medicine, there are also subspecialties. So I remember somebody saying that he or she wanted to go into sports medicine.
Yes.
One of the routes to sports medicine is family medicine. So if you want to work with like an athletic team, or if you want to work in a subdivision of orthopedics, there's a family medicine specialty for sports medicine. There's also OB as a subspecialty where family medicine physicians can do C-sections and other surgical procedures and get more advanced delivery practices. And then there's geriatrics as well.
Oh, there's lots.
There's a lot. So
yes,
whatever you want to do.
there are lots of
You're giving me.
yeah. So when you're thinking about just your bread and butter family medicine provider, though, this is a provider that's taking care of everybody from newborns. So, well, you can go for prenatal care to newborns to geriatrics. So the newborns to grandparents and everybody in between. And we are taking care of anything that comes up with that person in their life. And that doesn't always, it's not necessarily just the physical health care. Mental health, as Dr. Baiden brought up, is something that we also focus on and want to make sure that people are as healthy as possible with regard to their mental health. So that's something that comes up frequently and something that we need to help take care of for people. So whatever you can think of, family medicine is a gateway to care overall. And then, as I said, if it's something gets beyond what we can help you with, then we send you on to a specialist if necessary. So, and a little bit more into that. So, it's the gateway. Family medicine opens doors to a myriad of other career options and opportunities. So, a family medicine physician, if you think about just a traditional practice, family medicine doctors can do and frequently do continuity care. So So when I say continuity care, what do you think of? What does that mean? Any thoughts?
Lifespan?
The lifespan. So yeah, definitely lifespan. But this is like one of the continuity care means it's one of those terms that we use when we're saying, if you have your provider or your physician, and that's your continuity care provider. So it's usually those doctors that you make an appointment to go to, that you see on a regular basis for whatever you need to see them for, whatever medical condition.
That's one of the things I love about being family doctors. I've been in practice for 11 years now, so I have my babies who are now like about to go to junior high, and it's just so fun to talk to them about all of these different transitions. And then I have my teens who are now moms, and I get to have their babies, and so that kind of continuity or spectrum of care has also been really beautiful to have.
Yeah, and I did continuity care for over 12 years. And it was nice, yes, to have that continuity of care in terms of through the lifespan. I would have a mom that I took care of while she was pregnant, delivered their baby, and then saw mom and kid, through the years. And so that was nice, just to be able to take care of people through their lifespan. And then I had some patients that were, older adults that then, as they were getting older, became the geriatrics patient. It was like, okay, we need to think differently about your care now, 12 years after the fact, because other things, there are other things that we need to focus on now. So that was great as well. And then even end of life care, I did see some people at the end of their life that I, saw for years. People who had just moved to Utah, needed a provider, and I met them, and they met me. We started to take care of each other, and then things come up, and specifically I'm thinking about a cancer patient, and then I still saw them and helped to take care of them as they went through the end of their life, hospice care, and then subsequently she did die. And there's the one I'm thinking of particularly, but there are others as well. But you just see them through the end stages of life too. So that's what continuity care is about. It's about having your patients, they're yours, that you help to take care of. And those patients call you theirs. You're their doctor. You're who they want to go to, and who they'll schedule appointments for.
You are the follow-up doctor. That's what you can be. So when people say it's from the initial time of diagnosis and say, well, who are you going to see after this? It'll be your family doctor. Often that's the wrangler who will initiate a referral. And when it comes back and they get their information from the consult, it goes back to the family doctor.
So urgent care. So I transitioned my practice from continuity care to urgent care a little over 5 years ago now. And which is just a different way of practice, a different way of thinking. So urgent care, what do y'all think of urgent? What is that about? Something that you weren't planning came up and you need to see a doctor, right? Yeah. So
sometimes outside of normal practice hours. So it might be earlier in the morning or later after 5, right? Well, how many of you can go somewhere between 9 to 5, right? Are you busy at school? Do you need a different more option? Or maybe a Saturday. That would be more convenient for you.
Yeah. And then those things that come up. You have a cold or have respiratory symptoms and don't know if it's COVID, and in this day and age. Or you were outside hiking and you fell and you have a cut on your knee or wherever, or you fell and your wrist is really killing you, and you need to see if that's broken or not. A lot of times people will go to urgent care for that immediate acute care for something that's happened. And so that's what as I said, I've transitioned my practice to urgent care. And typically those are visits that are walk-in visits. You don't have appointments, you just come in and you're seen as available. And one of the mantras in urgent care is you see them, you treat them, and treat them. So when you come to urgent care, that provider is not thinking that, okay, I'm gonna come and take care of you and I'll see you later, how you're doing and next week. No, I come, I see you, what's going on today, and let's take care of it today if I can, or let's see what we need to do to help you get better. And then you need to go to your continuity care provider to make sure you're getting better, if not, then see what the next step is. So that's what urgent care is about. And a lot of people, so I transitioned my practice into just urgent care after many years of continuity care, but some people will come out of that. They go straight into urgent care because that fits their lifestyle.
And I think as you figure out what specialty or where you want to go into, you'll figure out what branch.
It's like somebody's trying to join somebody. Yeah.
There's even
locum tenens. I brought that in specifically because we have Dr. Ferguson here, who primarily that's his practice. But who knows what locum tenens is? What is that?
Is there like contracts where you do short stints at different places?
Yeah, it's like the traveling doctor. But yes, you work for or with a particular organization who will then find you places, and you'll have a contract with different health systems, and you'll go for typically shorter stints to practice in an area where there's need. But then, you don't typically stay there years long, years and years long. So, but I brought that up specifically because Dr. Ferguson is here. So do you want to say something?
Yeah. And also locum tenens is not limited to just family medicine. So, for example, your mentor, Dr. Anderson, which she's getting ready to go and do a locum tenens assignment, that's going to be about 2.5 months in psychiatry out of Michigan. So I started doing locums immediately after graduating from here because it's something I dabbled a little bit, looked at hospital medicine, which they will discuss as well. But I said, I think ER is kind of better because of my military background, and that's what I was doing in my last duty station before even starting residency. And I said, I would like to give this a try. And I started with one of my first assignments it was 2 weeks long in the middle of North Dakota, and I loved it. And I said, and I never went back. I'm still doing it. It's just it's more spread out now, so I can make time for y'all. But it is a big lifestyle change. I've worked in 8 different states, multiple different hospital systems. You have to be a bit of a chameleon to blend in with different staff and maintain certain level of credentialing and certifications to be able to bounce around this much. That's a bit disruptive to some, but single at the time, no children, I could, and a decent pay wage as well. So it also afforded a good amount of time off. But one thing it didn't do though is I wasn't a part of continuity of care unless somebody came back in those 2 weeks or that 1 week while I was there. I'm like, hey, happy to see you again. But yeah, that's another option that many of my peers weren't even aware of during residency. And part of that is just due to who's training you in residency. But I can always talk more about that later.
And then, hospital medicine. I did that for the first 6 years of my real work. Our residency program was so good at teaching us both inpatient and outpatient medicine. And so I think all of us felt prepared about going into a hospital setting. You did it for some time as well. But it just became too much. And I was doing nights and while I was building my practice. But it was a beautiful way to continue with certain skills and with complexity of patients. I was able to pay back my student loans. So if that's an interest for you too, this is a segue or a gateway for that.
Yeah. And so, yes, that's not something that I specifically have a bullet point for. So thank you for bringing up the hospitalist. And that's 2 different kind of areas of medicine, especially in primary care, that we can talk about. So another kind of 2 different categories of how you can practice, at least with traditional practice. So what is a hospitalist? We keep throwing that out there. Do you guys know what that means? Throwing that term out. Anybody online want to chime in? What is a hospitalist? Okay.
What do you think it sounds like?
Inpatient. Right. So basically, I am.
So say you got sick and you couldn't go home because that's how sick you were. You would need a doctor to take care of you in the hospital. Back in the day, there were docs, primary care docs, who would leave their clinical practice and go around other patients who were sick in the hospital. As you can imagine, that's a lot of work to have a balance of clinical patients and hospital patients simultaneously. So finally, a branch of medicine was developed where there are dedicated physicians who work only in the hospital, usually in shifts from like 7 a.m. to 7 p.m., 7 p.m. to 7 a.m., et cetera, or 7 on and 7 off, depending on what that contract is. But if you get admits or new patients from the emergency department, so that continuity that is needed, that PR can't say, yeah, you're not safe enough to go home for X, Y, or Z reason, then the hospitalist person or physician will take care of you for as long as you need. So if you have pancreatitis, your pancreas is inflamed, and you can't eat for a few days, that person's going to manage your nutrition, your liquids, make sure your kidneys and other organs are also functioning, etc. If you have a pneumonia, there are some people who have pneumonia or a lung infection that can be treated at home. Some people need more acute care like oxygen and IV antibiotics. So that's what a hospitalist would do.
Yeah. So there is that branch of practice of taking care of patients in a hospital setting, people who can't go home. But then there's the other branch of traditional medicine where you're taking care of patients in the outpatient setting. So more the clinic setting. People who can go home, you can, see them for your 20 to 30 minutes, how much time you have in a clinic, exam room, come up with a plan and have them fulfill, that plan to help them get better as an outpatient. So at home and while they're doing whatever else they need to do with their lives. So yes, those are the two different categories of traditional practice that I didn't put bullet points for. But that's something else, making family medicine even more diverse. That's another way of thinking of what you can do as a family medicine physician. You can work outpatient or you can work inpatient clinical.
And this is all before you even subspecializing.
Oh yeah, this is all.
You don't even have to get additional.
This is straight out of residency. Yeah, so this is straight out of residency. And yeah, so that's a good thing. So other things that you can do as a family medicine physician. So academia versus community medicine. Have you heard of those kind of differentiations? So academia are those physicians that are still teaching, basically.
Community physicians can teach too.
Yes, community physicians do teach, thankfully, because of course academic providers here, like you just strictly you can't take all of the medical students or all of the residents. So of course there are community teachers as well. But in academia, you're teaching, so you can even do didactic teaching with medical students as they are coming through and getting their lectures in the lecture hall. You do the clinical teaching as well in a hospital or clinic setting. But with academia, you're also working to improve or working to grow and build the field of practice. So with academia, one of the goals is for us to grow and improve family medicine. And a lot of times that's through research. And so with research, it's not necessarily in the lab, bench, pipetting. This is research in the community, working with patients, just trying to figure out different practices that can help improve healthcare. So research is something that's definitely focused on in academia. And so it's just another branch of family medicine that you can go into right off the bat, right out of residency. No extra, well, sometimes you need extra training, but that's something that you can definitely think about doing just right off the bat. So yes, it's open. So family medicine continues to open doors, and we started to allude to this in terms of doing specialization within family medicine. What are those things that you can do if you did want to focus on one particular area of medicine, there are a ton of specialties that you can do. And so this would be extra training after residency, usually what's called a fellowship, in order to specialize.
So any of you have questions so far? Anyone out there in the metaverse?
Yeah, anybody online have any questions at this point? All right, so specialization, and we've already alluded to this because sports medicine is one thing that was brought up by one of the participants tonight. Sports medicine is a very common and it's a popular subspecialization within family medicine. And sports medicine is basically you're doing an orthopedic fellowship, and you become an orthopedist. You are not an orthopedic surgeon, but you learn how to do manipulations, other procedures to help take care of those musculoskeletal injuries.
Like joint injections, joint aspirations, casting, lots of those different things. And our residency program, I think, is also really good about incorporating that, but I didn't feel like I needed to do additional.
Yeah.
So come to me. Okay.
So we do a lot in the family medicine residency program with sports medicine, but our residency program is directly affiliated with the sports medicine fellowship program as well.
So that's internists, like internal medicine residents and the residency medicine residents apply to get our sports medicine fellowship. This
is a route into sports medicine. So one of the things when I was in medical school, I was thinking about, well, what do I want to be? And one of my big visions was that I could be the team doctor for my kids when they were in sports. And so I thought, well, maybe family medicine is what I want to do so that I can do sports medicine and be the team. That was part of my thought process. That's not what I did for specialization, obviously. But that is an option to do family medicine.
In the interest of time, maybe we should go through all of them.
We definitely won't go through all of them. Just highlighting the major ones, I think the top 3. So the sports medicine obstetrics is another fellowship that's very popular and common. So in family medicine, you are trained to be able to take care of women who are pregnant and to deliver their infants, and then to take care of mom and infant throughout their lifespan. However, if it's a complicated pregnancy, then usually we're referring to OBGYN, unless you get extra training for more high-risk pregnancies, and usually that's what you're training for with obstetrics, and that will include C-section training, so that you would be able to be the surgeon, the primary surgeon during a C-section. You as a family medicine physician, so you don't have to call your OBGYN friend and colleague to come in and do a C-section. You can do it yourself. But usually that's just if you have the extra fellowship training in obstetrics. And that being said, if you are in a rural area, you don't even have to do an obstetrics fellowship, because there are family medicine physicians in rural areas who are doing this. They are doing the more high-risk pregnancy care even without fellowship training. But if you're going to stay in a big city like Salt Lake, then you would need to do fellowship in order to get that type of credential. And then another very popular fellowship, extra training that family medicine physicians do after residency is geriatrics training. We do have a geriatrics fellowship program here with the University of Utah. And so what is geriatrics? The elderly. So yeah, then you're going to focus on taking care of elderly patients. And a lot of times people will go on to just taking care of elderly patients that are in assisted living facilities or skilled nursing facilities or things like that.
Maybe even end of life care, maybe some hospice
Or
care.
palliative care, end of life care, yeah. So that's another field of specialization in family medicine. And then there are a myriad of others. Obesity, I brought that up because one of the videos we're about to see, one of our third-year residents is doing an obesity fellowship. I was like, oh, that was a new one that I've heard of, specifically just obesity. Public health, I did a public health fellowship. Well, it was called faculty development fellowship, but I got a public health degree with it. And aeronautics, so people who want to go into in the space, outer space, who want to be an astronaut. Family medicine can lead you into that. And there are a bunch of other subspecialties. Like if you just wanted to focus on, really, if you wanted to do infectious disease, the CDC, the Center for Disease Control and Prevention, they have a lot of fellowships, extra training for family medicine and other primary care providers, specifically in infectious disease. So it opens doors. Family medicine, you can do anything that you want as a doctor. And that's one of the appeals, definitely, to this field.
And there are emergency medicine fellowships too.
There are emergency
Some are, it comes down to the accreditation and, many places say, well, but it's not an ER formalized board certified training, but many more remote areas, places with that where a lot of ER docs like to stay where their toys are. They like to stay in those tertiary care centers where they have MRI, but they will often look to a family medicine doctor that's got ER, not necessarily fellowship training, but some years of urgent care and sometimes ER experience. And they're like, I want you because you know how to work with less resources. And that's often part of our training. I guess the only thing I would ask is, how long are those top 3 fellowships?
I think sports medicine is 1 to 2 years. OB, I think, is 2 or 3, depending. Geriatrics is 1. I think obesity, public health, are also about
1 to 2, depends on what you're doing. They vary, and it depends on how.
Yeah. There's also a pathway to addiction medicine. I know some people are interested in behavioral health, but addiction medicine has become a very needed type of subspecialty as well. And there's several family medicine physicians in this valley who have gone on for additional training to assist the behavioral health world and psychiatry world.
A couple of those pictures up there. So the picture of Dr. Ferguson and the picture of me, we're actually doing international medicine in those pictures. So that's something else that I didn't bring up. There are opportunities to do international medicine and primary care outside of the United States through family medicine and, of course, other fields too. But
one of my colleagues did a semester at CE, and so he was the ship doc for all these amazing college kids, and got to do a lot of fun acute care. And then they docked in several different countries, which was beautiful. And then in our clinic, we speak Spanish every day. And so that's another thing as a primary care provider, the ability to just really have that intimate and medical relationship with your patients. There's, again, so many things that you will morph into.
all right. Excellent. So kind of just some basics too. So we talked about family medicine, what you can do. So this is just average compensation and years of residency training just to come out and practice family medicine. And it's down on the bottom of this list. And as you can see, the 3 primary care fields of medicine, they typically get paid less than the subspecialties. And that's just our culture and our reality.
This looks like that, sorry, this was like that whole table from on November.
Yeah. You might have seen this before.
Yeah, so this is dated. So this is probably at least, I'd say, based on these salaries, 6 years old. And I think from the source I got it from, family medicine, it's much higher than that now.
But if money is your motivating factor to go into medicine in general, whatever specialty you're considering, this is not the field for you.
Yeah.
Because if money is your only thing driving you, you will not do
Don't go into medicine.
Yeah.
There are other things that you can make lots of money with without as much schooling. But so yeah, don't let money be your driving factor. And actually, in reality, pediatrics is at the bottom of the list. They typically make the amount of money in terms of medical providers, but we're not at the top, and that's not what we're in this for. Okay.
That being said, you can have several side hustles.
That's true.
So we could talk if you're interested in that. So I only work 3 days a week for clinical practice, but there's other things that I have my hands in, not just to supplement my income, but it's because of I'm all over the place in what I'm interested and passionate about. You have an MBA. I'm sure you have your hands in other things too. You know, like that. These are things that we, as family medicine, we are not just we're everything.
We are often more desired in non-clinical fields as well compared to other specialties because of our well-rounded background and training. So we're more likely to be put in a position as the head of a hospital or the head of a health system.
A medical director.
Yeah, because they're like, oh, they've taken care of everybody from 0 to 90. That's in their background. They've seen more in a very narrow scope, often subspecialists. So I'm very happy that I went into family medicine, and I've met a lot of other family docs all over the world. I've been able to respond to COVID crisis at a field hospital because of my hospitalist training. I had to kind of pull that knowledge out when I had to do it. And then later on, I'm like, oh, I'm back in the ED taking care of COVID patients. So now I have to stop my work up to here, but I know what's going to kind of be the end result. That's what's great about family medicine.
So 3 years of residency training. So graduate from med school, 3 years of residency, you're a family medicine doctor. So how do you become a family medicine physician? So college, you need undergraduate degree, and then you get into medical school. Medical school is typically 4 years, the traditional route, and then you will get into your residency program, which will include family medicine. So yes, it takes time. It takes years. And you guys are already in the thick of it with studying, and it takes time, but it's definitely worth it. Most definitely. But there is life outside of medicine, and life happens. My life pattern, I alluded to my first husband. So I unfortunately this is my second marriage, and I started my family later in life, but that's just the way my path is taken. So I'm in the middle with my current family. I've got 2 older ones from my husband's previous marriage, and we have the 2 little ones in front. So I have a 2-year-old and 4-year-old. But that's how my life is going. So being a mom, I feel like is probably 90% of my life. And yes, I'm a physician too. And it makes for a busy life. And I'm a wife too. Oh my goodness. I'm not going to leave my husband out of there because he's carrying me, taking care of too. But he's a great partner. And yes, we've got now Jamie on the left end, she's 21 and Sage is 19. So we've got a spectrum. So yeah, we're dealing with those adolescent things too. We've got a busy household. Yes, they're all at home with us all the time. Yes. So there is life outside. I'm also very involved in my church. Religion, spirituality is very important to me. That has helped to carry me through, the stresses and the ups and downs of getting to where I am in my career and in life otherwise. I mean, I'm from Los Angeles. Most of my family is still in LA. So I'm still involved in their lives. I was talking to my brother-in-law about graduating this summer and how we're going to get there and when we can coordinate that. So there is life outside of medicine that happens throughout the process. And it just makes your life it's fulfilling. It just makes your life more filled and fulfilling. I'll stop there.
So that's my little one. I'm a single mama. We had kids late. I'm now in my 40s. He's 5 now, and that is my pride, my joy, my everything. And I'm a better physician because of him. Very more patient and understanding, and explain things better. So I apologize to my patients 5 years ago. And we try to do as much as we can outside. I love hiking, snowboarding, mountain biking, road biking, rock climbing. I just like to be outside. That's where I get my mental health care from. And my family, my dad is here. That's how I came here. My mom and everyone else is back east in New York. And my mom has some mental health concerns, and so just did I hear whoop whoop? Okay, all right. And I think all of you know here, we don't just take care of ourselves, we take care of our family. And so being far away from family is difficult, but I'm glad to have the opportunity that family medicine provides. Again, I work 3 days a week, so I can take care of my other family.
How is the schedule like? Do you like pick whichever days you want?
In private practice, you do.
So as a resident, no. So first of all, in residency, after you're done with medical school, no, they basically give you your schedule. And that's hard. That was hard for me in residency, especially. Outside of residency, in fellowship, it's much better. So as I did my fellowship, I was doing coursework like you are for my public health degree. But then in terms of clinic and hospital care, I was able to choose, my hour. You have more say. There are times when you're on call that it has to be covered. So you work with your colleagues to figure out who gets what, in terms of what's going to work best for timing. And when you start off, at least in academia, a lot of times you take what you can get in terms of your schedule. Now that I've been around for a little while, I'm basically carving out my schedule. So, but private practice is what you want. You make your schedule from the get-go.
By being locums, for several years, I worked maybe, I'd have to say about 120 days out of the year. And that was it. The rest was off. Mind you, those were 12-hour shifts, often overnight, no 24 hours. So once you're out of residency, and I might have mentioned this before, you have to be in control of how much you want to work. So know that in advance when you're about to sign up with faculty. Know that when you're signing with a private group, and also when you're an independent contractor, because I wouldn't say it's feast or famine, but many people will not restrict you on how much you are willing to work. And so that's when that balance of life, work-life balance comes in, and self-care. So you can work 100 hours a week, but I would not advise that. That's not sustainable. But you can also
and
work
your job
3 days a
is
week.
not going to prevent you or stop you from doing it.
Yeah, they will let you work.
That's up to you. You have to stand up for yourself and say, nope, this is what I need. So yeah. Any other questions? Yes.
So do the lines ever get blurred between like what type of doctor is seeing which patient? Like with the urgent care, is it kind of random if a family medicine doctor sees them or an emergency medicine doctor sees them?
Oh, so if they come into an urgent care clinic to be seen, then you see whoever's available.
Okay.
You see who's available.
You might also see like a physician, you might see what we call an advanced practice provider, like a nurse practitioner or a PA, which stands for physician assistant.
So does an urgent care doctor in their work life, I guess, do they do the same things that like an emergency medicine doctor does?
To a point, not all urgent cares have radiology. So for example, if they don't have like a CT scan or ultrasound, they may not be able to assist people who have pulmonary emboli or who have a ruptured appendix. They might just say, no, you have to go to the emergency room. So like our clinic, we have that capability. We have an MRI, CT, ultrasound, and then our radiology reading group we can call. We have a lab there. Not every urgent care is built that way. We're not an ER, but people think we are, but we have a different acuity.
They can do often much of, say, maybe 75% that might end up presenting your typical ED. But also, there are such things as standalone ERs. But what's missing there? The hospital part of it. So once again, that person is being sent away.
Yeah.
So there are many standalone EDs that happen because of the staff training, and they maybe have a CT, but that's not much different than what we have down here on 9th and 4th. Or what the other bridge.
And that's another in family medicine is how we're able to save patients money as well as the healthcare system money. Because if we say we can probably do the majority of this here safely, would that be getting a hospital copay or an ER copay? That's another thing, and that's another way that we can advocate for people and our patients.
Good question.
Yes, definitely. So you mentioned before that you can do international work. How do you do that as a doctor?
University of Utah. No, I have to stop saying about the University of Utah, but they have affiliate programs. So they Guatemala, Peru, Ghana. Where else? I went to Ghana twice. Once as a medical student, once as a resident.
Thailand.
Thailand. There's public health programs, and so if you're interested, you apply as well. You can find a mentor to help you guide you to international travel. Once you're out of residency or out of that academic protection where you don't have that clear-cut path, there's all sorts of organizations that are looking for doctors to assist internationally. So there's opportunities in any field of medicine that you're looking for.
You can be anywhere from Tonga to the front lines of Ukraine if you wanted to.
And so my international work has been with nonprofit organizations, so non-university affiliated. I've done one trip, but most of what I've done has been with nonprofit organizations. And actually, that was from my connections at UCLA, and through UCLA connections in Peru. So that's just the nonprofit that I've been working with. But there are a myriad of ways to get involved internationally.
I have two questions. So the first one is related to the international. So I did like global health for my master's, so I am interested in global work, but do I have to specialize in, so I can subspecialty in anything and still have that international? Okay.
And then anything.
Okay. And then I am older. And so like for me, I'm approaching the point. I mean, I'm almost 30. You have a free from me or two. I mean, close. Okay. Oh, I'm on the other side. But like for me, like having a family is incredibly important, and I think you guys have like life after residency, and so ideally, I'm trying to figure out, because I have chosen to pursue medicine in a much later, not in a non-traditional fashion, and so like the work life and the ability to have a family while in school or around that area, I really want to consider, and so yeah, from you guys' experience with your colleagues and your own experience.
So we have accommodations. If you need to delay, that's fine.
When I was in medical school, one of my closest friends had a baby right before we started. She had a baby during medical school and during residency.
Okay.
And
there's never a right time to have a baby.
Yeah.
So, like, but it's true.
Yeah, and I'm sorry we don't have any. We have medical students with families now who are making it work. And one of like our third year residents says she's pregnant now, and people have they have their children, men and women. So I'm talking more female, but family comes when it comes, you know.
And there are accommodations made.
Yeah.
Aren't looked at.
Men and women. So it's not just
yeah, okay. There are laws against that.
Oh yeah.
We'll talk to ACLU.
Okay. There are coming for men and women. So it's not just women, definitely women. And traditionally it's been women, you know, first, but men have their parental leave time too.
There's AMWA, AMWA, American Medical Women's Association. They are very passionate about facilitating those accommodations for women. There's also a page for female physicians who have experienced fertility concerns because of their choice to delay. So there is a group, there's support, there is accommodation. So please don't let that deter you from pursuing a career in medicine. Check out AMWA.
More questions online?
Princess, Brittany, Zen.
I don't have any questions at the moment.
I think there's a first year.
There are a couple first years.
No, who just had a baby?
Oh, I don't know. Anybody from Florida just had a baby?
Not our women. We have several guys who their wives just had babies, but we do have a class full of there's guys with several children. We do have some female classmates with children and who are married. So everyone makes it work. So I definitely would say that obviously, it is kind of hard when you're having to study and you also have kids and everything, but that hasn't stopped them at all. So just kind of goes to the point that was just made about having kids in medical school. My classmates are doing it and they're doing pretty well. So
Doable.
Yeah, and I think I want to say at least there were several of my residency mates a year below me I think in my year. Annie Marsh and who was I can't remember.
Meg with my class.
Yeah, so I think almost every year there was a pregnant resident, and she didn't stop, she didn't stay for an extra year or anything like that. And also she was the year below me, and she was in the sports medicine fellowship out in Washington. And she had a kid in fellowship right after. So, and she didn't necessarily delay. I think she just got married, right in her third year, and then next year she was in the middle of fellowship, and she didn't have to extend. So it's very common, and I know even in the surgical subspecialties, for those that are considering it, they will accommodate. Do not think by you being a woman and applying that you're less likely to match or get in. Because they're like, oh, what if she gets pregnant during residency?
And if they ask that question, let me know.
You report us.
That's
You
done.
don't need to ask. Yeah.